Welcome to the Practicing Clinicians Exchange podcast series on exploring new options in managing the pain crisis of sickle cell disease. This is the first of two podcast episodes titled Current Understanding of Sickle Cell Disease, and will focus on the pathophysiology of sickle cell disease, including nursing considerations on recognition and initial management of painful vaso-occlusive events, provider engagement strategies, and prevention of painful episodes in patients with sickle cell disease during an emergency. My name is Alison Towerman, and I'm a nurse practitioner in the Department of Pediatrics at Washington University School of Medicine in St. Louis, Missouri. I will be your moderator for today's episode. Joining us today is Dr. Michael DeBaun, Director of the Vanderbilt-Meharry Center of Excellence in Sickle Cell Disease and Professor of Pediatrics and Medicine at Vanderbilt University School of Medicine in Nashville, Tennessee. This program is supported by an educational grant from Novartis Pharmaceuticals. This program is provided by Practicing Clinicians Exchange for 0.25 ANCC and 0.25 AAPA credits, with 0.25 credits applicable for pharmacology credit for NPs. To receive credit for this program, go to pce.is/sickle. Learning objectives for this podcast are to define the pathophysiology and manifestations of sickle cell disease, and to initiate a conversation on nonpharmacologic strategies for preventing complications in sickle cell. Dr. DeBaun, what are painful episodes in patients with sickle cell disease?
Well, first of all, thank you, Alison, for that introduction. And I also want to thank you for not using the word crises. It turns out that when we provide the medical care for our children and adolescents and adults with sickle cell disease, we prefer to not use the word crises, in part because it gives the connotation to the individual, particularly the family and the affected individual with sickle cell disease, that they don't have control over what's going on with their body. And to a certain extent, they do have control over understanding their triggers for pain and then managing the pain in a non-pharmacologic fashion to mitigate its impact on their daily routine. And we'll talk a little bit about that in a second. But to get to your question, which is what is a vaso-occlusive pain episode? It's an event that occurs in individuals with sickle cell disease that's extremely painful. The degree of pain is been described as having shattered glass run through your veins, being hit by a truck. And in several cases, we've had women who did not know they were in labor because they were told all their lives that labor is the most excruciating pain for a woman. And yet when they compared the labor pain to their sickle cell pain, they in fact thought it was trivial. So that gives you a sense of the magnitude of pain in an individual with this disease. Basic pathophysiology is thought to be related specifically to the red blood cells in sickle, polymerization of the hemoglobin, particularly during the deoxygenation phase when the blood is actually going to the lungs in the veins. And in fact, the lung is the organ that actually allows for those cells that become sickle to become reversible and round. And eventually, because of this abnormal shape of the red blood cells, there's a cascade of complications and cellular impacts that occur, including blockage of the microvasculature and ischemia to the bone and other organs that results in pain.
Okay, thank you. Thank you for that. That's a great explanation. So at your institution, how do you currently assess and manage patients with sickle cell presenting with vaso-occlusive episodes during an emergency?
Yes. So let's start off with the cornerstone of management of pain. It's trust. And so we spend an inordinate amount of time with our families, the adults, the parents of children with sickle cell disease, and the adolescents themselves, developing a bond, a provider-patient bond. Because once you establish that bond, then you can actually start to understand the depth and the breadth of their pain. So the first step that we initiate is to ask the patients to describe their pain. And then we ask them to distinguish their pain that they're currently feeling from their sickle cell pain. Too often, individuals with sickle cell disease will have pain that's completely unrelated to their sickle cell disease, but we attribute that pain specifically to their sickle cell disease, and then we prescribe them an opioid, when in fact, we would never prescribe an opioid if the patient didn't have sickle cell disease for severe headaches or for chronic back pain for sitting down in an abnormal position for a period of time in the absence of compression fractures or the like. So the first is the trust. Second is a vocabulary around their pain. And then when they come to the emergency room, we would like for them to specifically be able to describe their pain action plan and whether or not they have initiated their pain action plan. And so the pain action plan is really no different than the asthma action plan in the sense that there are staged approaches according to the WHO stepladder approach for management of acute pain. Typically, there's non-medicinal pain measures followed by non-steroidals for a brief period of time, typically up to 48 to 72 hours. We are hesitant to give non-steroidals for a prolonged period of time because of the acknowledged challenge of kidney dysfunction associated with non-steroidals, as well as peptic ulcer disease that can occur with non-steroidal inflammatory drugs. We then, from there, move on to a hydrocodone. We typically don't provide codeine because of the pharmacogenetics indicates that probably 10% or so of individuals with sickle cell disease don't metabolize the drug in a way that gives them relief from their pain. So we have eliminated using codeine in any of our pain action plans for over 7 to 8 years. We go with hydrocodone, and for the group of patients who need a long-acting opioid, we will give them a long-acting opioid and a short-acting opioid as well, with the recognition that the long-acting opioid, particularly MS-Contin, will not have its peak time to onset between 3 to 4 hours. And so the patient's in severe pain, and you don't want them to be waiting for 3 hours while they're waiting for that drug to hit a therapeutic level. So that's our general stepwise approach. And of course, if the pain action plan does not work at home, then they come to the emergency room. The key component of the emergency room evaluation is that if they haven't initiated their pain action plan at home, we consider starting that pain action plan in the emergency room, which doesn't make a lot of sense to people, but we want them to start on a regimen that they can continue at home. And putting an IV in to somebody who can actually have their pain alleviated with hydrocodone doesn't make a lot of sense.
Thank you, Dr. DeBaun, and thank you for underscoring trust, because I agree that really is so important. So when and how often would you say patients come to see you for vaso-occlusive events?
Well, we prefer them, and the patients prefer, to be managed at home. When you look at the strategy across the lifespan in adults and children, most pain events occur at home. And so we want them to manage their pain at home, in part because it's a better environment than coming to the hospital to be managed. There's a lot of challenges in most EDs, emergency departments, in managing sickle cell disease and pain, including disrespect, accusations of faking their pain, the prolonged wait times. In some cases, there could be 6 hours worth of wait in the emergency room, which is not to their benefit at all. Our strategy is, if you can wait until you come see us during the day, then we would prefer to see you at 8:30 in the morning than to have you go to the emergency room at 2 o'clock in the morning. That's the first. And then we go through this routine I just described. Once they get to the emergency room, and provided that they've done all the things that they can to attenuate their pain, then we take a good history to identify what the triggers may have been for their acute pain episode. In some cases, particularly in children, there is asthma exacerbation that may actually be the trigger for their pain. In some of the young ladies, there may actually be the onset of the menstrual cycle that may trigger their pain. And when you talk to these young ladies, we've documented this and have published this data from both focus groups and quantitative surveys. Women are able to distinguish their vaso-occlusive pain, which is their standard pain, from menstrual cramping or discomfort associated with the menstrual cycle. So you want to ask those questions as well. You want to address whether they have this, all of us tend to have, since we're sitting in front of computers for hours on end, chronic back pain or pain in our back, and how you distinguish that pain from the sickle cell pain is an important component of the discussion. And then there's overuse. I mean, some of our adolescents now are literally playing varsity sports. And as a result, they are like engaging in the everyday activities that athletes engage in, and they hurt themselves and they come in and say, I'm in pain. And we assume because they have sickle cell disease, it's pain associated with sickle cell disease. And last but not least, the common high school scenario is the student who's in the marching band who starts to have back pain and the like, and it's like, I'm in pain. Well, wait a minute, this is pain not with your sickle cell disease, it's over exercise. So We try to understand the circumstances of the patient, their activity level, and separate their sickle cell pain from their non-sickle cell pain. When they come in and they have their sickle cell pain, we go through this approach I just mentioned. Mrs. Towerman, can you provide us with some of the nursing recommendations for the management of pain episodes during an emergency?
Yeah. So first of all, the goal when a patient comes in with a painful event is to, of course, mitigate the pain as best as possible. So nurses should always start by performing a comprehensive pain assessment, asking about the location, the duration, and the intensity of pain. They should also pay attention to any nonverbal pain cues like facial grimacing, body positioning, guarding, changes in vital signs like increased blood pressure, faster heart, faster respiratory rate, or tachycardia. It's really important to ask the patient, kind of like you said, what he or she has tried so far for pain relief, when they last took pain medication, and what's worked for them in the past. We should be asking them about that individualized pain action plan that you mentioned, which a lot of these patients with sickle cell have, and which we encourage patients and parents to know. And the answers to these questions can really help guide the management plan for the current episode. So then nurses will administer medications, which might include those NSAIDs, opioids, and IV fluids that you mentioned. We should reassess pain frequently and advocate for further pain management if necessary, while, of course, monitoring for any oversedation. We should encourage increased fluid intake, rest, massage, the use of warm compresses, and then we might also consider other pain management strategies like distraction, breathing exercises, meditation, or biofeedback. But listening to the patient, or in children's case, their parents, is really key. They know their bodies best, and a patient's self-report is really the gold standard for evaluating pain. And we need to remember that there's wide variability in how patients might present and might express their pain. So some may not exhibit as much distress as others, particularly if they've experienced a lot of pain in their past or in their lifetime and have developed helpful coping skills. So we can't really make assumptions based on appearance alone. We really have to listen to the patients and families. And then before discharging them home, nurses should assess patients' and parents' understanding of painful episodes, including potential triggers and things to avoid. And we should ensure that patients understand how to take their pain medications appropriately so that they can continue to manage their pain at home.
Great. I want to ask you another question in this space. Great answer, by the way. Can you also provide the audience with key takeaways for patient engagement, prevention strategies, counseling, and improving patient clinical communication?
First off, it's really important that patients and parents know the type of sickle cell disease that the patient has and inform their emergency department provider of this, because this can help inform the management approach. And then second, like I said, a lot of these patients have individualized pain action plans, which, like you described, have medications they should be taking based off the severity of their pain. These are a great resource for both them and the parents, but also for providers. We go over these action plans in the outpatient clinics, but it's important for providers in the ER to recognize that sometimes it's been a little bit since the plan was last updated, so there may be a need for dose adjustment. So even though they might present the individualized pain plan in the ER, it's important to still review them. And then finally, in terms of prevention strategies, patients should know triggers for their pain and strategies for avoiding them. So they may want to avoid extremely cold temperatures or find ways to reduce stress. But also it's really important that they take any medications that they're prescribed, some of which might help prevent painful episodes, as we'll talk about in the next podcast. So that concludes this podcast. Thank you so much for listening today. Remember to visit pce.is/sickle to take the post-test and claim your credit for this activity. We hope you enjoyed this podcast and invite you to listen to our second podcast titled What's New in Sickle Cell Disease and Vaso-Occlusive Episodes by also going to pce.is/sickle.